Good afternoon, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, we need your evaluations to give you CME, and you'll find it by following the link in the chat at the end of this talk, or on our website, or on our email advertisement. And your comments are very important to the planning committee. So please do give us comments and we will use them to plan future programs. It's my great pleasure to welcome our speaker for today, Dr. Ferdinand Hui is the Chief of the Neurointerventional Surgery Division at the Queen's Medical Center. He's also Clinical Professor of Radiology at the John A. Burns School of Medicine, University of Hawaii. He's the Senior Fellow at the University of Hawaii's Office of Innovation and Commercialization. He has authored over 170 scholarly publications. He's editor of one medical textbook and an associate editor of the American Journal of Neuroradiology. He developed a helicopter-mediated physician transfer model to accelerate care for stroke patients. The program is called HeliStroke, while building stroke systems for the NIH Stroke Program, and he's co-founder of Radiology Artificial Intelligence Lab, or RAIL, at Johns Hopkins. His present research focus is on elucidating mechanisms for intracranial venous congestion, in keeping with his role as chair of the Committee for Venous and CSF Disorders of the Society of Neurointerventional Surgery. We're actually going to invite him back again, either later this year or early next year, to talk about his interventional roles. He's also a venture partner at Verge Health Tech and a general partner at Meta Angels and co-founder of Pistevo Healthcare. I also want to introduce Dr. Michael Hong. He's going to be co-presenting with Ferd, and he is part of the Vascular and Body Interventional Radiology Division at Queen's. And prior to coming here to Hawaii, he was at the University of Colorado. So welcome, Ferd and Michael, and please go ahead and start your presentation.
So hopefully everybody can see our screen. My name is Ferdinand Hui, and it's a pleasure to work together with this wonderful young man. We both and several others of us do the procedures we'll be talking about today. I'm going to start this off by just introducing the topic. Dr. Hong will then talk about vertebroplasty, and I'll finish it up with talking about sacral augmentation. A couple of our slides. Okay, good. This is our clinical information. We're going to be talking about two major groups of diseases, kyphoplasty, and that was what Dr. Hong will be talking about, restoring height in spines. We'll talk about sacroplasty. How do you deal with sacral insufficiency fractures in a minimally invasive fashion? We're also going to talk just very, very briefly as a teaser for the next time. We've just recently formed a new section in the Society for Neurointerventional Surgery for cerebral venous and CSF disorders. We're very interested in where this will lead. There are venous problems that they treat in peripheral interventional as well. Any place where the veins don't work well, that organ doesn't work well. And go figure, if you do it to the brain doesn't work well. If you have patients you suspect with this problem, refer it to us. We're going to start with this slide. And the question, of course, is why does a young woman at age 50 look like this and then become a dowager hump in the next 25 years? So Dr. Hong, would you take it away? Let's talk about kyphosis.
Hey everyone, thanks for letting us join today. Michael Hong, I'm one of the interventional radiologists here at the RAI group. We may have spoken on the phone, but looking forward to working with everybody. So all this is kind of centered around the pathology of osteoporosis, which is this systemic skeletal disease with low bone mass and all these architectural changes on the microscopic level that involve the deterioration of normal bone tissue, and then consequences related to a lot of osteoporotic fragility fractures that we're going to get into in different locations. This is very common that we'll get into as well, and the complications of which are becoming more and more common, contributing to a very large public health problem, as you can see here. There's over 100 million people at risk worldwide from osteoporotic fragility fractures, 44 million alone in the United States. That's data from over 20 years ago, so this number has increased substantially actually in the interim. And there's over 1.5 million fragility fractures in the United States, 700,000 of which almost half are involved in the spine, also in the hip, wrist, and kind of this smaller cohort of other fractures. And obviously, we're mostly going to focus on the spine fractures today. There is also a substantial economic burden beyond just kind of the patient-centric and symptomatology of all of this, related to osteoporotic and the associated fragility fractures. Greater than $20 billion per year of total economic burden, which, as you can see, is even more substantial than heart disease and breast cancer. Additionally, these costs are also can be seen spreading to out-of-hospital networks involving nursing homes, people away from work, with, again, pretty substantial projected daily costs that are only getting more severe as we see an aging population. This is a picture of what happens in osteoporosis of the spine. You get a lot of instability and loss of the normal architecture of the marrow and the cortex. If you can see my mouse in this picture of screen right, this is the normal appearance of the marrow. This is the disc space, and as you can see here, there's pretty much complete collapse of the vertebral body at this level. You can see a little bit of this wedge left, but almost completely collapsed here, where you've got disc on disc kind of morphology here. As we'll get into, there's different kinds of fractures. There can be traumatic fractures, where we see in a younger, healthier population where there is an abnormal force on kind of normal bone. But as you get older and there's a lot of osteoporotic changes to the bone and architectural morphology, you can have really normal load bearing on abnormal bone that is going to cause severe fractures like we're seeing here. So back pain is the number one cause of years lived with disability in the United States. Like I mentioned, there's upwards of 750,000 vertebral fractures in the US per year, resulting in a lot of hospitalizations, and very importantly, increased morbidity and mortality risk, both at 5 and 10 years from vertebral compression fractures. These are, again, projected to increase in number and expense in a rapidly aging population that we're seeing. And again, here's some of the comparisons that we see for spine fracture and hip fracture in terms of disability days per fracture: 14 for the spine and 18 for the hip. And here's some of these degenerative changes that Ferg was referring to in that original picture. Is as you develop demineralization and fractures, you get kind of growing instability that we're going to talk about in terms of kind of some morphologic changes, and then of the bone itself and also of the surrounding soft tissues, and this kind of progression of exaggerated kyphotic curvature that you see most often in the mid and the upper thoracic spine. This is kind of a pictorial representation of the normal spine with progressive height loss and compression abnormalities moving in the screen middle and screen right. You can see kind of the vector of the force here is going to be along the axis of the spine in something that's normal. All of the pressure from above can be evenly distributed, really utilizing the gelatinous components of the intervertebral discs to spread out the force and the vector mechanisms. As you get progressive collapse, all of that changes, and you get kind of this instability that kind of leads to this self-reciprocating mechanism that leads to more height loss, more instability, more pain, a lot relating to periosteal changes, inflammation, and then abnormal stresses on the ligaments and the soft tissues outside of the bone itself. So how do we diagnose vertebral compression fractures? On the history side of things, we kind of referred to this before, is that sometimes you can get abnormal loads on normal bones, which is our typical trauma population here. But for this particular population, in the geriatric realm, is really normal loads on abnormal bones. This will present as fairly acute onset pain that's actually localizable and impaired mobility. not so much in terms of neurologic symptoms like radiculopathies or motor or sensory dysfunction. Physical exam here is actually going to be reproducible point tenderness at midline posteriorly. That's going to be over the posterior spinous process, the most protuberant thing at midline. And that's going to reproduce the kinds of pain that brought them to see us in the first place. And again, neurologic symptoms like radiculopathies are a little bit less common in this population. And the findings on the imaging, CT and MRI, should really be concordant with the level attributable symptoms that they're coming in with. And there's a few treatment options that we have for vertebral compression fractures, kind of here in increasing invasiveness, conservative and non-surgical management being the first and most common method, open surgery in terms of laminectomy and fixation, and then kind of this in-between population here of minimally invasive vertebral augmentation, which can include vertebroplasty and kyphoplasty, and spine jack, which is a newer agent regarding height restoration that we're going to touch on briefly. So what does conservative management look like for a lot of these patients? It's typically a combination of these three: bed rest, immobilization, and pain control. These work, they're functional in terms of trial mechanisms to see how people are going to tolerate kind of a little bit of rest and relaxation and ultimately trying to get back to their normal function. But as we're going to see, there are a number of complications from these relative conservative management options that have some undesirable side effects. This is kind of the magazine representation of what an immobilization device looks like, a TLSO brace. This guy looks very comfortable, but in reality, this is kind of what it looks like in real patients. It's bulky, it's large, it's uncomfortable. It really has a lot of limitations in terms of function and ability, and are generally poorly tolerated. And in addition to this, bed rest and immobilization, which has the obvious effects: increased risk for pneumonia, falls, DVTs, depression and social isolation, that has a larger burden than we may initially expect. And then the final component is pain control. And once you get into the narcotic territory, you can have the obvious effect of constipation, fall risk, cognitive deficits, things that we would like to avoid, particularly in this population. And here's kind of representation of the human cost, things that may not, a lot of us may not think about to begin with, in terms of the social isolation, the functional impairments that you see with these kinds of fractures, that result in a lot of decreased activity, depression, lower self-esteem, loss of independence, diminished social roles. These all have a heavy mental burden in a population that's susceptible to these kinds of things. This is from a study back in the late 90s regarding the effects of pulmonary function from vertebral compression fractures. And one thoracic vertebral compression fracture can cause about a 9 to 10% loss of FEC. And then again, all of the deconditioning processes here can lead to increased risk for pneumonias as well. So in patients that don't do well with conservative management, we have kind of this in-between minimally invasive option for vertebral augmentation. So what is it? It's a minimally invasive procedure to improve biomechanical stability of the fractures, to prevent that self-reciprocating process of height loss, pain, and progressive kyphotic deformities. Cement is instilled into the vertebral body through a 1 centimeter incision in the skin. And different kinds of vertebral augmentation are available, but overall they've been proven to improve pain, prevent subsequent fracture, create a little bit more biomechanical stability, and decrease the morbidity and mortality rates compared to non-surgical management patients that are failing those kinds of mortalities. So these next couple slides here are kind of what the procedure entails and what it looks like, and how we're able to use the anatomy of the vertebral bodies to really perform this procedure. This is almost always performed with conscious sedation. It's very well tolerated. Really, the only painful portion of the bone is the periosteum, which in this kind of pictorial representation is this area right here on the very outer surface of the bone. That actually responds very well to local anesthetics. And once that area is numbed up, you actually have a lot of pain control that you can induce just from a little bit of lidocaine. Once that's performed, it's a small incision, typically 1 to 2 centimeters, and a lot of aggressive Innovation in the device realm has allowed us to be even more minimally invasive, transitioning from what was originally bipedicular or bilateral access into unipedicular access from one-sided approach, which gives you equally as robust and durable treatments. So these are kind of different views of vertebral bodies. This is a sagittal, axial, and kind of coronal views. And what we're really utilizing here for this transpedicular axis is this region of the vertebral body called the pedicle. You can see it's adjusting lateral to the central canal. And then above and below those regions, you have the neural frame, and obviously all areas that we're trying to avoid going through this bone. This is kind of what we're looking at when we do the procedure under X-ray, is we're trying to identify this structure right here, which is the pedicle, and then take the needle safely through the pedicle, keeping very close eye on the adjacent neural foramen levels, the spinal canals, and positioning the needle in the vertebral body here, allowing us to get ipsilateral and contralateral access for installation of cement. The difference between vertebral and kyphoplasty is basically just kind of comes down to a couple of deviations in the procedure itself. Vertebroplasty being installation of cement with placement of a single needle. Kyphoplasty, the only difference being is that we're insufflating a balloon and creating a channel for some of this cement to sit in, which we'll talk about in just a moment. Of course,
I apologize. Apparently, my colleague is having problems with the stroke, so I'm going to go run to a stroke. So I'm going to talk about sacroplasty really quickly. I'll give it back to my good friend and colleague, Dr. Hong. So you're sorry for skipping ahead. I apologize. Now you're dealing with a bunch of procedures, and you know how we're all ADHD. So I want to just talk to you briefly about sacral fractures. Yeah. You know how to talk about this. So sacral fractures, 18% mortality, prolonged bed rest can result in atrophy, very similar. Here's a patient that we did at Hopkins. This is a sacral insufficiency fracture. You'll see the step off here. That's where the break is. The fracture line goes up throughout the sacrum, and it's typically H-shaped when you look at it on a plain film or a MRI or a bone scan. What we're trying to do is just, these patients can't get out of bed because their sacrum is no longer stable. It hurts. So what we can do is place needles. I'm using curved needles here, but you can use any type of needles. You get into the fracture space, and then you start infusing cement. And what we've done is now create a little smiley face inside the H. And once we're done, the fractures are now fused, and they can get up. This woman was able to get up and walk post-op day 0. So it's a pretty gratifying thing for us to be able to do. The advantages are that instead of decompensating and at risk for PE, higher risk for PE while you have them in prolonged bed rest, you can have somebody potentially get up immediately. This is a meta-analysis of sacroplasties that have been published in the literature. The overall point of these assessments is that you get a very dramatic result, a reduction in VAS scales immediately post-op that's sustainable, and ODI scales also an immediate drop and sustainable post-procedure. And so the individual studies as well as meta-analyses suggest that there's benefit on trying to get these patients sacral fractures fixed and shortly after they're diagnosed. That way you can reduce the amount of decompensation and damage to their fragility index. I'm going to let him go back because we've got a stroke on the table. Thank you very much.
All right, sorry for the interruptions here. I'm going to work my way back to spine augmentation. So I think we were just finishing up here, just kind of brief procedural details. This is an explanted vertebral body with a cerclage wire around the actual pedicle. Again, this is kind of the route that we're taking transpedicular through the pedicle to gain safe access into the vertebral body. This is the kyphoplasty, the balloon-assisted or the cavity-assisted portion of vertebral augmentation. You can see kind of the anticipated progress here from left to right. Here's this wedge deformity. transpedicular needle. A balloon is mostly there to create a free space to fill with cement. Sometimes, depending on the fracture morphology, you get a little bit of height restoration, not the primary goal of kyphoplasty, but sometimes an added benefit depending on, again, kind of fracture morphology. And then installation of the cement into the bone, creating a little bit more of this biomechanical stability, prevention of the periosteum from having so much mobility. The periosteum, again, what's causing pain here, and then stability from these fixations. So you can see kind of the before and after, a little bit of height restoration, but most of the benefits here coming from biochemical stability. Here is one of these curved needles that are performed from one-sided access. You can see the original kind of introducer needle through the pedicle here. And you can see how far you get across to the contralateral side with some of these new technologies. An 11 gauge needle, you can get to the same spot on the contralateral side of the vertebral body through even pretty impressive fractures, this being the superior end plate here and the inferior end plate here, getting a lot of purchase from very small access sites. This is when you exchange that curved needle for a balloon, insufflate the balloon, create a cavity, maybe get a little bit more height restoration, and then instill that with cement. What we're looking for is some of this denser kind of cement forming in the cavity that we've created, but also some of this more amorphous cement filling. What you're looking for there and what it actually is the cement creating these little interdigitations in the marrow, which instead of just all this globular component of the cement in one spot, gives you a little bit more of a robust stability throughout the entire vertebral body as opposed to just one of those little segments. So what do we know about vertebroplasty? How did it help and why do we know this? This is often a tricky population to study. There's a large heterogeneous volume of data, but overall it does reduce pain compared to the best surgical management. You may have come across this RTVOF trial that was done in 2009. This was a randomized controlled trial that compared the superiority of vertebroplasty over sham. And this was kind of a groundbreaking study that got a lot of attention, and it demonstrated that vertebroplasty was not superior to sham. This harbored a lot of scrutiny of this study, specifically related to their choice of the control. And unfortunately, this study led to de-emphasis of vertebral augmentation, which resulted throughout the 2010s of a pretty substantial increase in the number of untreated vertebral compression fractures. You can see from this right here is that the number of procedures decreased by about a third and was accompanied by concurrent increases in the number of fractures that went untreated and overall increased mortality in the geriatric patient population. This was in spite of two subsequent trials that demonstrated benefits of vertebroplasty over sham. That led to a lot of uncertainty in the treatment algorithms for these patients for a long time, the better part of a decade. So much so that to the point where they needed a little bit more robust data that they couldn't really overcome with trials. And they created one of these multi-specialty panels, a combination of neurosurgeons, hospitalists, interventionalists, geriatricians, to come up with an expert consensus about what is appropriate for these patients, since some of this data can be a little bit difficult to interpret. And this really helped create a clinical care pathway and appropriateness criteria that really helped identify some of the best candidates based on a couple of different criteria that we can go over. These are a couple of Kaplan-Meier curves talking about all-cause mortality that I kind of want to get back to afterwards. But you can see that the all-cause mortality in these populations is almost as bad, and in some cases, even worse than hip fractures for men and women here, respectively. Speaking to some of these gender discrepancies here, women with vertebral fractures have a 5-fold increase in the risk of new fractures and a 2-fold increased risk of hip fracture. Of women who do suffer from these vertebral fractures, 20% will have another one within a year of their original fracture. These are a couple of studies showing improved outcomes in pain reduction. What I think I would like to get to is identifying who are really the best candidates for vertebral augmentation. And this was from some of that data from the multi-specialty panel. that was identifying some of these clinical care pathways. They kind of subdivided this into major and minor criteria. Patients, with favorable and unfavorable fractures in terms of who's expected to do well after one of these fractures. And overall, what we're looking for in terms of people who are going to be good candidates to come to us with these kinds of fractures are, in general, patients with positive MRI findings. That can be performed on a CT, but preferably an MRI. We're looking for height loss on the MRI, and then on a couple of sequences that are showing fluid edema and inflammation that's associated with the actual level of compression. There's a couple of other findings that really warrants a lot of attention and support moving forward with vertebral augmentation. Those being worsening vertebral height loss, greater than 25% height loss in the vertebrae. In my mind, the most important thing here, which is functional impairment, and then kyphotic deformity. So people who have positive findings on their MRI and have severe pain, they have functional impairment that's interfering with their daily activities. Those are people that you should have a very low threshold to send over to us for an evaluation, and probably someone who's going to do very well in terms of the symptomatic improvements from vertebral augmentation. And this, I think, was our most recent patient that we saw, was severe pain requiring hospitalization, precluding somebody from going back to their nursing facility. This is kind of the algorithm that was created from that expert panel. Just kind of a little bit of a busy slide here, but identifying who it is based on their symptomatology and some of their history, that's really going to benefit from the vertebral augmentation. We'll see here that they have advanced positive imaging on the MRI. They either have worsening symptoms or they have 1, 2, or 3 of these unfavorable factors that we had talked about: worsening height loss, severe functional impairment, over 25% height loss, and then kyphotic deformity as well. Regardless of how well the procedure goes and how good we are from a technical perspective, this is kind of the most important parts of the procedural care in terms of preventing people from having additional fractures, which is optimizing the medical management of their osteoporosis. Before that really gets optimized as an outpatient, we are often set up for same-day discharge, probably more often for the acutely hospitalized patients happening on post-op day 1. Our current follow-up, if you've been in touch with us through Pacific Endovascular, is receiving a phone call from us in 1 week, an in-person clinic appointment within the next couple of months, tracking and progressing their symptoms comparing to before the procedure, and then typically in the 6 to 12 month follow-up range as well. We have very minimal weight-bearing restrictions depending on the fracture morphology, how much height loss is, how much instability we're anticipating. But all in all, these patients are okay to start ambulating same day, if not the next day, with the typical assistance of physical therapy as an inpatient. Here's a quick case. This, I believe, was back at the end of last year. This was my first case of a kyphoplasty actually here at Queens Hospital. There was a 94-year-old gentleman, history of osteoporosis, already had a left hip fracture with a replacement, and had a fall from standing at his nursing facility. He had an acute T11 vertebral body compression fracture with about 20% height loss, not quite meeting that 25% that we were looking for on some of that data, and a couple of remote thoracic compression deformities at T7 and T12. He had in the range of 8 to 10 out of pain, 8 to 10 out of 10 pain attributable to this T11 fracture, and actually some radiating symptoms, which is a little bit more atypical for the fracture. Sorry, a little bit of an adjustment there. This was his MRI. You can see here things that are bright are fluid containing. Here's the fracture kind of based in the anterior body. And here's some of this edema that's in the marrow around the actual fracture plane itself, which is, again, one of those positive findings on advanced imaging. There's edema here, there's instability. Presumably there's a component to inflammation here causing the discomfort and the pain. And that's one of the most important findings on imaging here that suggests a person's going to do well from a vertebral augmentation. The next couple pictures here are from the procedure itself. So here's this unipedicular or one side access, needle going through the pedicle. We're going to see that advance through the pedicle into the vertebral body. This is that curved needle that's helping get a little more space with a smaller access coming both anteriorly and across the vertebral body. A balloon creating a little bit of a dead space. Not looking for a lot of height restoration here. And then cement installation. This more kind of denser globular component is the actual filling of the fracture itself and of the cavity that we've created using the balloon. And a little bit more difficult to see, but some of the stuff here we're seeing on the patient right is a little bit more of that amorphous cement that we're looking to kind of work its way in between either smaller fractures or work its way in between some of the marrow components to give, as opposed to just one site of cement, a little bit more of a uniform distribution of cement in terms of creating a little more robust augmentation there. This gentleman, I believe, went home on post-op day 1 or 2. We gave him a call 1 week later. His pain was minimal, had reduced from a 10 out of 10 at its most severe to a 2 out of 10 at its worst. He was off pain medications by the time we were calling him and ambulating well with his walker, which was at baseline. Very satisfying to see this gentleman kind of get back to his normal routine. There are a couple other renditions of vertebral augmentation. The spine jack, a little bit more invasive, a little bit larger systems, more so focusing on actual height restoration as opposed to the biomechanical stability component of this alone. This is really really aimed to restore height in patients who have kyphosis and try to create a little bit more of that upright physiology, just addressing some of those, like, again, self-reciprocating deterioration in terms of height loss and more instability. These are these little metal cages that are left behind, deployed kind of open like a spring, but otherwise is performed in a fairly similar fashion to what I've described already. The difference being is that we're trying to restore height here. Another kind of component of this, again, performed in a very similar fashion, is bone ablation. This is often performed for patients with site attributable pain from metastatic deposits in the spine, typically that are in kind of the posterior portions of the vertebral body and in the pedicle itself. These can be performed in conjunction with vertebroplasty or kyphoplasty, where there is cement injected into the actual lytic lesion itself. Again, just kind of creating a little bit more instability from a relatively, in this scenario, normal looking marrow to really an area with no mechanical stability whatsoever. The ablation portion of this being performed on the way out through the pedicle, which is often a site of pronounced pain, where you get kind of a combined therapy here in terms of pain control, and then hopefully debulking of the tumor in a fairly tenuous location close to a lot of nerve roots in the spinal cord. This is a particularly bad fracture from a metastatic lesion in the spine here, almost entirely involving the vertebral body. There's breakthrough the posterior components of the vertebral body into the central canal that you can see here, also involving a lot of the posterior elements, which have a lot of instability implications. This was a combined kyphoplasty and ablation. A lot of big cement filling into this open cavity. A little bit of height restoration here, it seems, as well. Have to be very careful in this area to prevent cement from extravasating into the spinal cord or thecal sac region. But this was performed very well. Again, got some height restoration and also an ablative component in the pedicle from the access. I think that is all I've got. I'm sorry I lost Ferd. He is a busy guy, but any other questions on anything that I've talked about in terms of the vertebral augmentation? Sacroplasty is not my particular area of expertise, so I would probably have Ferd follow up and answer any questions about that specific procedure. But happy to answer any questions that have come up about anything so far to the best that I can.
Thank you so much, Michael, for an excellent presentation.
Of course,
I wanted to open it up to our audience for questions. You can unmute yourself or you can put something in the chat box if you would like to. Any questions?
Hi,
Cody?
I have a question.
Yeah.
Thank you so much for your presentation. It was wonderful. I have a lot of patients that end up coming to SNF at the nursing home with very severe back pain, and it really does take away so much of their function. What would you suggest is the best timing for sending these patients for referral or to even do the procedure? I wonder if, do we miss opportunities to identify these candidates during the hospitalization to send them directly before they struggle at SNF?
Do we miss a window? I would say no, there's not a specific window. There was kind of some earlier data a couple of decades ago about really getting into the kind of subacute phase of the fracture, which kind of started at the 6-week interval. I've been in scenarios where I've treated fractures within a couple of symptom onsets and also probably several months afterwards. People do pretty well almost regardless. In terms of logistics, is how can we timely treatment for someone? If they're an inpatient, you can just kind of get in touch with us via the pathways, just contacting the general line. And if they're an outpatient, either at home or in a nursing facility.
Michael, I'm so sorry. Your audio is kind of cutting in and out. I don't know if you need to be nearer to the mic or something. Sorry about that.
See. No, thanks for letting me know. Is that any better now that I'm closer?
That's much better. Thank you.
Okay. Sorry. I don't know how much of that you caught. So if they're an inpatient, I think the easiest way would be get in touch with the typical IR service line is just calling us directly. We'll see the patient. We have a new consults kind of service line for inpatients and outpatients being created right now. That's going to be mostly run by our nurse practitioners. So they'll be able to see patients either on the day of the request or the following day, depending on the time. And that will be an in-person evaluation, consult notes, a little bit different compared to how things are set up right now, which is a little bit more of an amorphous, vague process. As it stands, that's hopefully coming out in the next month. So that will be what inpatients look like. And for outpatients, it will be a similar referral to Pacific Endovascular. The easiest way to do it right now would be to place a procedure request for an outpatient IR kyphoplasty. That will typically be protocoled within 1 or 2 days. And then depending on our clinic availability, probably seen in clinic within 1 to 2 weeks for an assessment. And then the planning component, which could be an additional 1 to 2 weeks as well.
Thank you
Michael,
so much.
I noticed that many of our audience are not part of the Queen system.
Mhm.
So they may be part of other hospital systems. Do the other local hospitals offer this process? And then if not, how would they refer to Queens for this procedure?
I can't speak for all of them. I believe they offer this at Kaiser, just because I know a couple of the IR docs over there, and they're very proficient, albeit a very different insurance population that we're talking about. Polymomy, I believe, does some of these, but I don't think in the same volumes that we or the Kaiser docs would. So I can't speak to too many of the other hospitals here since I'm relatively new. But if they are to be sent over to us, that's typically done, since they're not in the system, is a call to our office, and then some of our schedulers and coordinators would get in touch with us in terms of verifying and approving. Both the procedure and the clinic visits would be the easiest thing. And I will send you the Pacific Endovascular contact information afterwards, and my email as well, just so everybody has it for ease of access.
Thank you so much. Marina, did that answer your question?
Yes, thanks so much.
Of course.
Okay, and Al, do you want to ask your question?
Yeah, I often I didn't realize IR folks do these procedures. I mean, it makes sense that you do, but my experience has been mostly the spine ortho guys are the ones doing these in the community. So just wondering if all IR folks do these or what?
I would say most IR docs do these. I can't speak for kind of different generations of IR, but I would say most of the kind of early to mid-career IR docs have had a lot of intensive training for these kinds of things. So I would say most interventionalists, again, that kind of depends on the training, have at least a small to moderate amount of experience with these. A smaller number doing really aggressive spine work like spine jack or ablation. But I would say most IR docs have proficiency in this realm, yeah.
Cody, do you want to give your comment so everybody hears it?
I think that it's really helpful to have an established pathway to expedite, just screening and scheduling of these patients. Because when I get them at the SNF level for rehab, it's kind of race against time. Because if they don't make progress in therapy, they drop off of insurance coverage for therapy. And it's really hard if we can't manage their pain, but have to wait several months for an outpatient referral if we think it can help their pain and mobility. So kind of lose an opportunity.
Okay,
Yeah.
I will try to make some, address a couple of those issues in terms of the ease of contact and then also expediting actual clinic evaluation and the procedures.
Yeah, thank
Um,
you. A lot of them are like in the nursing home, SNF therapy. They might have been seen in the ER or hospitalized with back pain. And sometimes the vertebral fracture is found as kind of incidental, or they mention it, but they don't really do anything about it. And then just send them to us for other issues. But then scheduling for eval of vertebroplasty or any kind of augmentation usually ends up secondary to that, even if it's holding them back from therapy.
Sure. I would say we do have a lot of kind of new service lines. So the logistics, I think, are being addressed finally here with a lot of different transitions and a couple of new staff members. One thing on your end that may help expedite ultimate time to intervention would be, once you do identify the compression fracture, there's attributable symptoms, is just getting an MRI of whatever it is, the thoracic or the lumbar spine without contrast. Once they do make their way over to us, we're seeing them in clinic. We have a little bit more of what we need to ultimately get them scheduled and kind of make a good clinical assessment. So that would be a good thing to order is if you find a compression fracture on a CT or an X-ray, even if there's uncertainty if that's what's causing the pain, an MRI will both identify that there is attributable pain at that level. It's a new compression fracture from whenever the prior comparison is. And again, if there's edema or inflammation on the MRI, that's typically going to be the biggest factor that would get them over to us and get them cleared to go ahead and move forward with the augmentation. And for his back, we were just kind of talking about some of the logistics surrounding what it is that can expedite the referral and ultimately expedite treatments.
So three things, as you probably, this was call me in, I don't know, gangster. No, I'm not going to go there. But the bottom line is if you have a patient that you'd like us to refer, problem one, we literally don't have enough machines in Hawaii to take care of the patients at the volumes that we would like. That will change. Write your senator, kidding. Talk to us and let us know. We'll keep track of the backlog. I personally think that these patients need to be expedited. Unfortunately, with all the emergencies that we do here at Queens and everywhere else, it takes some work. But if you send the patients, we will do our best to get them done. One, two, as the patients are writing in and saying, "Can we please get our patients?" It gives us a narrative with the administration to say, "Please get us more rooms." We're currently working on doubling the number of rooms we have available for neuro and body interventions. I personally believe that we actually need 2 to 3 neurovascular rooms, and we probably need 5 to 6 body rooms for the needs that are in Honolulu. But that's going to take a lot more time. Everybody here knows how complicated construction is in Hawaii.
I will get your 2 cents on the referral
Sure.
pattern. For inpatients, they can obviously just get in touch with us with a phone call. For outpatients, I'd recommend it, depending on if they're in the Queen system or not, it's just getting in touch with us at Pacific Endovascular. Anything different if they wanted to contact you?
So I'm going to type it in this. This is, if you want to talk to us, and we have every intention of working as a team, as seamlessly as possible, his team and my team. I'm giving you our email, neurointervention@queens.org. You can send all patient referrals there. This is checked all the time. Phone calls don't work very well. Faxes are ±2. Neurosurgery is currently backed up by 300 cases in a referral queue.
Wow.
So if you email here with requests for spine intervention, I will probably dole them so that their team gets some, we get some, and try to take care of the needs. I fully believe that our patients need more of these in this island, and we look forward to working with you guys to take care of their needs.
Thank you,
Did he
Ferd and
explain-
Michael.
Did he explain spine jack enough for you guys? Any other questions about spine jack? It's a car jack for your spine.
The picture was worth 1,000 words, I think. It was good.
Wonderful. Oh, and if you didn't, I'll just state this. We've reviewed one of the papers that we did at Hopkins was looking at our kyphoplasty results, vertebroplasty results versus spine jack results. So there is a substantial statistically significant difference in the height restoration with spine jack. It's definitely more effective at height restoration. The caveat is if you send the patient late after they've already sclerosed and partially healed, there's not much of an effect. So if you're intending on restoring kyphosis, you want to send them to one of us earlier, not later.
Any other questions from our audience?
Thank you for inviting us, Kamal.
Thank you,
for having us.
Ferd and Michael, for an excellent presentation. Very, very useful. And I'm sure you'll be getting emails for patient referrals.
Right, I'll leave my email here as well. Not to detract from the importance of vertebral augmentation, but I'm coming with an interest in a couple of procedures that would heavily benefit, I think, a geriatric population, specifically related to prostate artery embolization and genicular work in the knee. If you were to have any patients with symptoms from BPH or symptoms from chronic osteoarthritis of the knee in patients who are not interested in surgery, we're offering procedures that are minimally invasive done as an outpatient setting for BPH in the prostates and also degenerative changes in the knee. Happy to send out a brief message to you that as well that you can then share as well. But here's my email.
Michael,
there.
perhaps we could have you give a grand rounds on a couple of these topics. I think
Sure, be happy to.
it would be these new kinds of techniques. I think everybody would benefit hearing from them. We'll be in touch for sure.
Great. Thank you again for having us.
Okay. Thank you very much, everyone. Don't forget for your CME credits, Michaela has put the link in the chat box. You do have to do evaluations in order to get CME. Okay. Thank you again, Ferd and Michael. Bye-bye.
Bye. Thank you.